Welcome, everyone, to the Bob and Brad Podcast live event with Rick Olderman. Today, we are talking about stiff, sore, or injured. You can ask us anything you want from a physical therapy perspective. Let's just keep it to that. We are not good at giving relationship advice, unless you are, Rick.
Nope.
So we will be live for an hour. Anyone watching, feel free to ask a question and we will answer the best we can with our capabilities. If we don't have enough people tuning in, I do have some generic questions I will ask and we will kind of go through them as well. But before we get going, Rick, do you want to give people a little information about your background, your website, and where people can find your books?
Sure. My name's Rick Olderman. I'm a orthopedic physical therapist for about 30 years now. I've written books and I have online programs. You can go to www.rickolderman.com to find those. And yeah, that's good enough.
Sure. So we had a question come in already this morning, actually. Looks like someone asked it. They probably knew we'd get to it. So Char Willie says, tight calves, sore quads, reduced foot flexibility, and knee inflammation. So I'm assuming she wants any tips that can help. I think if we address some walking patterns and then
Shar, I'm not sure if you can hear me. Looks like Mike just went off the air. They were having internet issues earlier, so they may have again. So I'm not even sure if this is being recorded, but I see that you have tight calves, sore quads.
Hi, sorry, my internet cut out again.
Okay. Now, what's interesting, Mike, is that it shows that it's still live and countdown on my end. Is it
Yep,
recording me even when you go out?
it's still live. I left
Oh,
it.
okay.
I left it running, so it's still running.
All
So
right.
yeah, if I drop out again, just keep talking. I
Just keep
apologize,
talking.
people
Okay.
watching.
Uh,
What did you say while I was gone?
I didn't say much. I just waited and waited, and
Oh,
then your screen finally went black, and then I saw the live thing was still going. I thought, oh, maybe I should start talking.
my apologies,
Now
everyone.
I know.
So Char Willie has tight calves, sore quads, reduced foot flexibility, and knee inflammation. So I had suggested maybe we talk about walking patterns. We can talk about a night splint, and then any other tips you may have.
Well, the thing I'm kind of curious about here, Mike, is the sequence of these events, because that could affect how we answer this. So, Char, if you're on, can you talk about which came first? Were your calves tight? Did your foot have issues? Was it your knees that were first in this sequence? Have your calves always been tight? Have your quads always been sore? Give us some detail about how this began, so that if this was a result of having an extra long running day, well, then we know why it's all happening. But if you're sedentary and this just suddenly happened out of the blue with no reason whatsoever, that could mean different things, especially
Yeah.
since it's a bilateral issue in both calves, both knees, so forth.
It looks like her question came 8:45 this morning.
Oh,
So I
okay.
don't think she's on right now unless she
All right.
happens to be back. But I mean, considering we don't know these things, I would say something good to look at would be your walking pattern. Do you want to talk about heel striking and forefoot walking?
Yeah, but here's the thing, Mike, is I don't typically find tight calves resulting from poor walking habits, you know, typically. This is the
Sure.
unusual thing. And so, especially because most people are heel striking when they're walking,
Yeah.
so their calves are frequently turned off. And so this is what's kind of perplexing about this is why I wanted some more information. So, and the fact that she also has tight or sore knees leads me, if it's both calves and both knees, it makes me wonder if there's something more systemically going on that's affecting both legs at the same time, if both are being affected at the same time and to the same degree.
Yeah, everything looks like it's plural.
Yeah, so by systemically, I mean this could be something that's going on at the spinal level that is affecting both legs neurologically, like a disc issue or stenosis or something like that. It could be, a disease process. This is why I wanted a little bit more information. If this is due to, in response to an activity, then we can rule out a lot of things. But without any other information, given that it's bilateral, both calves, both knees, I'm thinking automatically some kind of central or systemic issue. But we don't know her activity level either. So
Sure.
it's a difficult one to answer with just that much information.
Well,
Yeah.
Char, if you happen to tune in, feel free to respond. We do have another question that came in. It's a pretty generic one. You can answer it. Where can I get the yoga balls in the background?
Oh, my yoga balls. Oh, I just got those on Amazon. So yeah, not
Pretty.
a hard one. So that's an easy one. So, the size of the yoga ball generally relates to your height. And so if you're a more petite person, you might want a 45 or 55 centimeter. And if you're usually around, I think of it as like 5'10" or taller, then you might want a 65 centimeter ball, but I'm not sure what you'd be using it for. So it's difficult to, I just use mine for exercising. So sitting on and things like that. But some people use them, like, for instance, their chair desk or the chair of their desk. And then we might need to be a little bit more precise with what we're recommending there.
I found in the clinic we got like 3 different sizes, and even like it seems like if we're doing balance stuff, the bigger ones usually are a little bit easier than the smaller ones. Obviously, the size of the person really makes a big.
Yeah. And going back to Char's question, I don't want to blow this off because it could potentially be a fairly serious thing. But I just wanted to talk about briefly, Mike, the relationship between tight calves and knee pain. And so if that's okay with you, maybe this would help Char a little bit too.
Sure.
So when people stand and when they walk, typically they are locking their knees straight excessively, too often, too long, all that kind of stuff. What happens is that in and of itself tends to shorten the calf length, because if we're standing here, right, and the knee is locked backwards straight, then the muscles connecting from the knee, the calf starts above the knee and goes to the heel. So if the knee is locked straight, then that is shortening the calf. And then there's a muscle deep to that called the soleus. Char, that may also be tight. So typically what that does is it shortens the calf muscles, which then kind of creates a cyclic problem that it then becomes harder to unlock the knees when you're standing and walking because the calf and soleus are so tight. And so just if you're caught in this loop, if the knee is perpetually in this locked position, there's a little muscle behind it called the popliteus muscle, which runs from the lower inside of the tibia to the upper outside of the femur. It's a rotational muscle, but it helps guard against knee locking. So this could be, and I found that the popliteus muscle is is a big instigator of knee pain. So so if you're locking both knees frequently when you're walking, when you're standing, for instance, I'm not sure what conditions this is all happening, but if you're locking this perpetually, then the popliteus muscle may become irritated because it is running from an inside to an outside. It helps control the rotation of the knee joint. And so when it's in spasm, because the knee is locked too often and too long, that then creates kind of a compression of the knee joint in a rotated position. Similar to, if you were to wring out a rag, and as you wring it out, your hands are getting closer and closer. And that's exactly what's happening with the knee joint if your popliteus muscle is in spasm. So it creates increased compression at the knee joint, and that could be causing the chronic irritation of your knees. So just a hypothesis of what may be going on, because we don't really have that much information, but I didn't want to blow that off because there could, and I didn't want to scare you thinking, oh my gosh, you've got a spinal issue or whatever. This could easily be a biomechanical issue, but we just don't have enough information to know to guide you on that one, Char.
Kaylin, who also asked about the yoga balls, has more of a PT question. So I need to strengthen my legs and improve my balance. I'm 60 and have worked my full career at a desk in computer. I'm noticing loss of strength and forgot about a squat. What exercises can I do that will protect my knees and improve my balance?
You want to start with that one, Mike?
I mean, some of it's going to depend upon your limitations. If you want to hit something that just focuses on legs, I think sit to stands are fine. They're basically a squat, but it's very safe and to a safe depth. And then if that becomes easy, you can always progress to staggering your stance more. So one would be more forward and one would be back. I don't know if I could show it in my chair right now, but unless you have some other options.
Yeah, I think one that I like to do is we put the ball. I'll see if I can demonstrate it against this wall here.
Oh, right. Sure. Ball wall squats.
Yeah, ball wall squats. So we put the ball against the wall, and the key here is that you want the ball like low in your low back or upper pelvis area, so that I don't even know if you can see me, Mike. But anyway,
okay.
The ball is right there. And then this allows the feet to come away from the body more, which is much more gentle on the knees when you do squats. Usually if you're standing up from a ball, like if you were doing squats from here, now my knees are over my feet, and that creates a lot more compression in the knee joint and is tougher, especially if you have tight calf and soleus muscles. So generally I begin people with a wall squat because you can lean against the ball's absorbing some of your body weight, and you can control easily the depth that you want to go into. And then you can always work down from there. You can do holds at the bottom, you can do pumps at the bottom, all sorts of things. But this having the ball against the wall is a great way to start exercising the quads when you're using a fit ball.
Yeah, that'll just be one exercise. That's a good beginner one. If you're comfortable doing some sort of lunge progression with maybe holding onto something and putting a pillow on the floor so you're not, putting too much force on your knee, you can certainly do that if you feel safe with it.
Mm-hmm. And then another one, Mike, that I like, especially since she mentioned that she's sedentary, and it's likely that maybe her balance isn't the greatest. So I like doing the one where you're standing, and then if your balance is poor, you would just stand and lift one foot off the ground, and you want to make sure that your trunk is straight up and down and not wobbling, or your hips aren't jutting out, things like that. And if you can do that easily, then you can start by moving this leg out and in for 15 reps, and then switching and remaining tall as you switch to the other leg. This stance knee is soft at all times. And then you reverse back to that again. You do it 3 times back and forth for 15 reps. And you have to maintain a tall spine, because what this is doing is strengthening the lateral musculature so that you don't start, a lot of spine pain and hip pain comes from asymmetrical lateral hip musculature strength. So the hip will jut out, or people will fall to one side. It's all because their hips are weak asymmetrically. So this is a nice exercise, to do to strengthen the hips while you focus on being tall on the stance leg that you're standing on. And then of course you can always add finally an exercise tube to that, standing on that with both feet, and then you have now resistance doing the exercise too. Again, 15 times to each side, 3 times through. So those would be the 2 that I would probably start with the most.
We have a question from Kate. This might be a little out of our realm because we often give carpal tunnel to OT, but we will do our best. She says, what exercises are safe with mild to moderate carpal tunnel? I'd like to do some basic strength workouts, but I'm not sure if it's safe to strengthen without worsening my carpal tunnel. And then she followed up, example, thinking about 2 to 10 pound dumbbells for basics like bicep curls or beginner kettlebell exercises, nothing with heavy weights. Yeah, I would say with carpal tunnel, often if you're in a neutral position, it's not as bad. It's usually when you start to get flexed more, people start to have more issues. I think a lot of it you're just going to have to go based off of feel, and if it feels like it's getting worse while you're doing it, I would probably back off with it. But other than that, I mean, like tubes are fine too, or resistance bands, like Rick was just showing, could work as well.
Yeah, so I always like to understand why the carpal tunnel is happening in the first place. Is this happening in both wrists, or is it happening just in one wrist? Does this person work on a computer a lot? Is that the source of the carpal tunnel? If you're working on a computer, then when your hands are in this position, the wrist flexors are tightening while you're typing. So it could be an ergonomic issue that's contributing to this, where your ergonomics are not ideal to rest your hands in maybe more of a neutral position rather than in a flexed position. That could help. And then also, another thing I found, Mike, is that a lot of people with carpal tunnel have reduced deep forearm rotator range of motion. So an easy way to test this would be you start here with your hands by your sides, and then you simply rotate your thumbs down. Now, the tops of the wrist should be able to rotate 90 degrees in this position. But if you're doing that and you find that an elbow starts to slide away from your body to do that, that means that you have tight forearm pronators. Your elbow moving away is your compensation pattern to get that hand in that position. So that is an indicator that your, what would that be? That would be her supinators are tight, all right? And then to test the pronators, again, you start in this neutral position and you rotate both palms up. Again, the wrist should roughly be able to get to 90 degrees, maybe 80 degrees. But if you do this and your elbows seem to squeeze into your waist in order for you to rotate your palms up, then that means that you have tight, deeper pronators. I have found, and there's a pronator quadratus and a pronator teres. So I have found, especially with people who type a lot, that it's the pronators that become excessively tight. And I have found that by stretching the pronators, simply by doing a simple stretch where you just take the wrist and you start stretching it into that rotation where it's restricted, and you want to hold the arm above the wrist, not below in the hand, because then you're going to torque the carpal bones, but hold it above that carpal area and get that stretch going. That seems to alleviate a lot of carpal tunnel syndrome symptoms for a lot of people I've worked with. And then, of course, lastly, this could actually be coming from shoulder blade dysfunction that's causing a neurological impingement at the neck shoulder area that then is feeding into the hands at the C7, C8 junction in your cervical spine.
She did follow up. It's in both wrists. She uses braces for sleeping, and she does work at a keyboard, but is pretty aware of positioning with it. So she's careful, she said. So
yeah, so all of that's great, and I really like the wrist splints during sleeping. That's an important one. And then then I would go into the testing for the forearm pronators and supinators to see if their deep rotators are tight. That is one that, frankly, I don't know of anyone I was never taught to check that in PT school. I don't know of any PT that does. It's just something I figured out along the way that seems to be helpful for a lot of these types of conditions. So that would be my other recommendation. And regarding, biceps, triceps, all that kind of stuff, yeah, all of that's fine, but not sure if that's really going to help the carpal tunnel symptoms that you're experiencing. So I always feel more strength is better, but we have to understand why the carpal tunnel is occurring in the first place, and don't lose focus on that.
I think the question was more just she wants to start strength workouts, but she has carpal tunnel. I don't think she was strengthening for carpal tunnel. I mean, that's the way I'm reading it. But
okay, got it. I wasn't sure if she was trying to resolve it or not.
Yeah, I would just say go based off of how it feels too. If you're going to start strengthening, like if it starts to react and get worse, then you have to back off or modify something. But
yeah, Mike, what do you think about like hand gripper devices to strengthen the hands for something like that.
I've never used it with carpal tunnel because the only like times I've had an issue where my hand, like I don't have carpal tunnel, but my hand is like locked up and seized up on me back when college because I used to clean windows and it's a lot of like awkward movements. But like normally flexing like made stuff worse for me. Like when I did that.
Yeah.
And I don't know if flexing, like I don't know if working the extensors would be better.
Exactly. That's what I was thinking, is maybe putting rubber bands around the tips of the fingers to strengthen the extensor muscles so that they are more in balance with the flexor muscles.
Yeah.
Maybe that would be something nice.
I used to have a rubber band in here, but I don't know where it went. Then so you just loop it around your fingers and then just work on extension.
Yeah.
Like that.
And along those lines, if you do wrist extensor curls, that would also strengthen the extensors of the forearm and offset and help balance out the strength between the flexors and the extensors of the forearm.
Yeah, it seems like most people are stronger with flexors, so flexing, and then also their grip, just because you hold things. Like most people don't extend that much. So
yes, yep.
We had a question coming from, where did it go? There's Melissa. She said, I recently had knee replacement surgery and need some good exercises to help my bend and strength. I'm 6 weeks out. Well, Melissa, the first thing often I do with knee replacements is focus on motion first, because once the motion starts coming back, then you kind of progress to strengthening. There's many ways to bend a knee, I would say, and everyone's a little different. Some people do better just lying on their back and then doing heel slides to bringing their heel towards their butt. If they aren't getting a lot of momentum, I'll have them use a longer belt and loop it around their ankle and then pull back. Otherwise, I've had people go on their bed if it's by a wall and put their foot up on the wall and then let gravity slide down. You can also use your other leg to help push back in a seated position. I'll just kind of back up, see if I can show it. You just kind of bend back like that. You probably can't hear me. That's a very direct microphone.
We could hear you.
Oh, okay. But yeah, you can bend it that way. What also a step stretch. I don't have a step in this room, but you can put your foot on a step and then try to push your knees over your toes. Some people I've worked with that. Other people I've even had sit in a rolling chair like I'm in, keep their feet planted and just roll forward. So there's lots of options. I guess just what works best for you is really the main key there.
I think one of the first questions I have is, are they not seeing a physical therapist?
I was gonna say your PT probably has a bunch of.
That's kind of confusing me a little bit. Is if you've just had knee replacement surgery, you should be in physical therapy. They should be showing you all of these things.
Yeah.
So I have two other points, Mike. One is that I find it generally easier to move your body towards an appendage rather than move the appendage towards you.
Yeah.
So like that recommendation you made in the chair where you roll the chair over your foot.
Yep.
I find that people can get their range of motion much more aggressively by sliding their body to a fixed foot rather than trying to slide the body to the foot to a fixed body. It's just so much easier. And along those lines, one that I really like to use was if you're lying on the floor, you have your foot up against the wall and your knee is bent, you're on your back with your foot is up against the wall. And so you just slide your butt towards the wall, which will bend your knee. And and that's a really easy one because your foot can't slide and your body weight is holding everything down. So you can't really cheat that much. So that's another good one.
She does say she's having PT. She's just looking for
okay, good. I was a little worried.
Well,
don't rely on just us.
Melissa, I will say that I've worked with patients that, either bending or straightening is harder. Most people have one way that's challenging. With bending, a lot of it depends too upon how much bending you had before the surgery. Because I've worked with some people where they didn't have much, and it's like you're working from years of tightness as well. So that could be some of it. But also, if you're further out, some people I've worked with, early on we use ice, but they'll put heat, but more up on your thighs. So not right on your knee, because sometimes your quads can start really getting tension and holding a lot. and fighting you when you're bending. So sometimes if you heat them up first and then do your bending, that can kind of help.
And then two more things I just want to mention. If you can replay this back to the beginning of the very first question I answered, was about this woman's knee soreness because of the popliteus muscle. I have had tremendous success by massaging people's popliteus muscles after total knee replacements or other knee surgeries and gaining incredible ranges of motion, because that popliteus muscle, it goes into spasm as a result of surgery. And so if it's in spasm, it will reduce both your flexion and your extension. So, write this down, Popliteus. That's how you spell the muscle. Ask your physical therapist to massage it and measure and then remeasure your knee before and after the massage. Have them massage it for about 5 minutes. And I can almost guarantee that you will see an increase in range of motion just by massaging that popliteus muscle. And then the last little bit of advice I wanted to show Mike was that thigh stretch that I like to do is a nice good one. You had mentioned, putting heat on the quad. And so I think she said she's about 6 weeks out, right?
Yep.
So she can start thinking maybe about doing a thigh stretch where you start like this. And let's say this is the surgical knee. You would just lower the leg down like this. And initially that knee is not going to bend much, but you can gradually try to bend that knee, and that will stretch the quadriceps that are feeding into the knee that may be contributing to the lack of range of motion that she's having.
Kate, who was the carpal tunnel lady, just had a follow-up question. Thanks for the ideas. Do you think planks are safe to try if they don't seem to bother me while I'm doing them? Yeah, planks are probably fine because you can keep you normally rest on your forearm and your wrist is in a neutral position. So that really shouldn't bother you. I think the things that bother carpal tunnel the most is like pull-ups or pull-downs where you're really holding hard, or any type of like rowing because you really have to grip. Any type of like pushing might be fine. Like if you do push-ups or any machines where it's pushing, so you don't have to grip as much. I think anything where you really have to grip, you'll just have to be the judge of how much it's bothering you.
Yeah, two things about that. Thanks for your follow-up, Kate. Is like if you're doing push-ups, I wouldn't do them on the ground first. I would do them at a higher angle so that your wrists don't have to go into that severe flexion or extension. So you can get away with something like this instead of having, the wrist in full extension while you're doing your push-up on the ground. So start with a higher object there and see how that goes. And then you can always work down lower. And then going back to the plank, because I'm a big scapula person in terms of upper body function, if you're doing a plank, what you can do is you can round yourself away from the plank and then sink yourself into the plank to strengthen your serratus and scapular muscles around this whole upper body system too.
I would say if you're doing, I guess we just assumed you're on your elbows for planking. If you do a straight arm plank, they do have like those little push-up handles, or you can even hold dumbbells and grip because then you're in a neutral position.
Yeah. I just feel nervous about that for a carpal tunnel.
Yeah.
Just any kind of pressure through that carpal area.
Start with elbows.
Yeah, elbows bent. Did I not show? I meant to mean that your elbows are bent when you're doing that.
Yeah, no, I know what you meant. I was just
okay.
in my head, I was like, well, I guess you can plank in a tall position. Technically, it's just a push-up, but
yeah.
So if anyone else watching has questions, feel free to tune in. We kind of went through these ones so far that we have gotten. I will fill some time with some generic questions until someone else has a follow-up here. So, okay, just said great, thanks, Tips. Okay. Since we were kind of talking about, well, I don't want to talk about that.
Uh-oh, here we go again.
Am I back?
Mike, your internet, it seems to be going out. All right. So while you're dealing with that, Mike, I will talk about our question I had from someone recently, or a comment. I made a Quadratus lumborum video on my YouTube channel, and this person was happy. What I try to do is I try to condense things down to make them more simple than typically how they're represented in medicine. So, Mike, I'm talking about Quadratus lumborum.
Okay, I could hear you, but apparently I wasn't there. So
Okay.
I left
Yeah.
and came back. And
Yeah.
then
I just kept
okay.
going
Okay, that's fine.
since we learned that. So anyway, Quadratus lumborum is a common complaint that many people who have one-sided back pain or something like that are told by their practitioner that oh, you've got a tight QL or Quadratus lumborum. The Quadratus lumborum goes from the iliac crest up to the lowest rib and inserts into these vertebrae. And the Quadratus lumborum does not act alone. So it's acting together with the obliques, the deep abdominal obliques, the latissimus dorsi, and all of that. So all of these other tissues are likely also spasmed in addition to the Quadratus lumborum, but it's just felt more here because it's a smaller, deeper muscle. But why is something like this happening? And this is just what I said in the video. Typically, this whole area is in spasm because of something happening lower to it. What happened that then causes the hip to hike up like this to get off of this problem down here. So if you all are dealing with Quadratus lumborum issues, look to in 80 to 90% of the cases, it's in the same leg. It's some older problem in the same leg. And your brain has this weird neurological reflex pattern called a cross-extensor reflex pattern that it tries to get off a problem down here somewhere by hiking the hip up to get off of that. And that's what is typically behind chronic Quadratus lumborum spasms. And then in 20 or 30% of the cases, it's that you've shifted off of the opposite leg, and now this leg is overused, and now your brain is trying to get off of that again. So this could be the source of the problem over in the opposite leg in 20 to 30% of the cases. So
we had another question come in from Barbara. So what's good exercises for mild case of thoracic scoliosis with the concave side to the left? So I'm guessing, is this concave to the left? I mean, this is my left.
yeah, so I'm curious. Is it
Barbara.
Barbara, do you also have lumbar scoliosis? It's interesting just to comment on a thoracic scoliosis.
She should be here, but I'll let you know when she says something.
Okay. So typically, do you want to start with this one, Mike, or not?
No, you can go.
Okay.
Scoliosis. Right. I work with back pain, but scoliosis is kind of like.
All right. So scoliosis is a medical term that simply means lateral curve. A lateral curve could be a functional lateral curve, or it could be a congenital lateral curve. This is why I asked whether she has lumbar scoliosis too. If she has lumbar scoliosis,
she does not.
Okay, so this means that it may be there may be a functional cause of this lateral scoliosis in the thoracic spine. It's just I've never heard of someone just having a thoracic scoliosis as opposed to without a lumbar scoliosis before. So I wonder if this is due to asymmetry of use of their body. So typically what happens is so typically what happens within the thoracic spine, if you have a scoliotic curve, then there develops the ribs start to split out and you develop a rib hump. That makes it hard for the shoulder blade to get over that rib hump. And so usually subconsciously what happens is a person will either allow the scapula to be further away from the rib hump so it doesn't have to contend with it, or they'll squeeze the shoulder blade to the spine to put it on the other side of the rib hump closer to the spine. So, it's kind of 50-50, whatever choice that person does, because rolling that shoulder blade, the scapula, over the rib hump is kind of irritating for a lot of people. And so it's not so much, and the scoliosis is what sets up that whole rib hump issue that then messes up the scapula. And if my memory serves me correctly, if it's a concave, which means I'm going to guess that concave means that the curve, the bowl of the curve is on the left, And if that's the case, then I would expect the rib hump to be on the right scapula because of that. And so that's the thing that throws a lot of people off, is that they're having right scapular issues. They think it's because of something on the right side, but actually it's due to a lateral curvature on the left. So first, being aware of whether and your therapist, if you've worked with one, should have told you whether you have a rib hump that you're contending with or not, that is impeding the scapular issue. And so I'm not sure if her complaints are with thoracic pain or with unilateral scapular pain. If it's unilateral scapular pain, then this is likely why that's happening. So, I typically don't try to change lateral curves mechanically. What I do is I look for asymmetry in function and fix that, because if we can make function symmetrical, that then tends to even out a lot of the forces, or at least slow down the progression of the lateral curvature of the spine or the scoliosis, if that makes sense.
She says, I have osteoarthritis and lower bulging discs, also disc degeneration. Is this in the thoracic spine, Barbara, or are you saying your lower back, like your lumbar spine?
I'm gonna guess lower back.
Yeah, she's saying lower.
Yeah. So what I would do, Barbara, is I'm not sure if you are doing any kind of upper body strengthening at this point, but hopefully you're seeing a doctor or a physical therapist to guide you more than Mike and I can guide you, because a lot of this depends on how things are presenting in terms of your function. So what I would say is I think a general light strengthening program would be a good place to begin. And part of that program, that I would include, is that row exercise. Here, I'll just move myself over here again. And I do rows, like this, so I'm supported. And then the row is like this. And for you, Barbara, what I would recommend is, and this is what I tell everyone, is to make sure that you feel the shoulder blade moving away from the spine when the arm comes down. And then to initiate this pull up, squeeze the shoulder blade to the spine and then bend the arm. So initially, you may not even use any weight at all to find your scapular function, to get that moving and controlled in a good way. And then you can start adding light weights to that. But that would be one I think would be a good one for you, in addition to the regular old biceps, triceps, and things like that.
She said she's not currently working with anyone. Yeah, just because when someone can see you in person, Barbara, they can give you a more specific, tailored program to your needs, because they might notice some other deficits like we can't see.
Exactly.
You're not here, obviously.
Yeah. Yeah. There's just so much when you deal with so Barbara, the thoracic spine is the seat of the shoulder blades. And so, if there's dysfunction in the thoracic spine or the rib cage, then it does affect the upper body, the shoulder blades, which are the foundation of all upper body movements. That's why they're so broad and flat boned, just like the pelvic bones are broad and flat, because they determine how the whole rest of the upper body system works. And that's why you need, I would think, someone to assess how all of this is working for you, to give you more specific information. If you have a lateral curvature, it likely means that there is asymmetry in how this foundation of your upper body system is working. That's why I'm a little hesitant to give you too much information. I just don't know how you're presenting.
And if you're having like low back pain issues too from those disc bulges, they could help address that too.
Yeah. I think you need to find someone who can assess you more specifically.
We have another question in. This username's interesting. 3BB Mac. I'm just gonna say BMac. I have sciatica on front top right, lower leg, right back. Thought it was going until I stretched to reach something right knee inside. I'm assuming it's just sciatica on the right side, it sounds like.
Mm-hmm. And it's on the front? Is that
it said it's on the front lower leg, right back, and then they stretched, and then it's something right knee inside. Well, I'm guessing it goes inside then.
Oh, it's on the front of the lower leg. I thought you said the front of the upper leg initially. Front of the lower leg?
Yeah, it says front right, lower, front leg, lower right.
Front
Do you,
leg.
BMAC, if you're here, can you clarify just because we're confused? So it sounds like it's in the front though, and it's not in the
Yeah,
back.
you typically don't run into sciatic pain in the front of a shin,
Yeah, it normally
right?
goes in your low
That would
back, in your
that might
buttock,
be
and
an,
then down the
yeah,
back of your leg.
that might be an anterior tibialis. If it's in the front of the thigh, then that may be actually anterior femoral glide syndrome issue, where the hip bone is tracking incorrectly in the hip socket, impinging tissue in the front of the leg.
Oh, sure, and referring down into the.
Yeah. So so there's some questions here, but she has right-sided back pain for sure, right, Mike?
Yeah, because it says
Okay,
back pain, and then it
all right.
says, yeah, that was just a leg.
And the back pain is on the same side as the symptoms in her right leg.
Yep.
So to me, that says that she has a right side bending problem, which means that this is the right side.
I have
So,
no idea if it's a he or she, but
oh,
there's no
okay.
picture.
Yeah, sorry about that.
Them.
So likely wherever these symptoms are, because it's both back and leg on the right side, it means likely you have a right side bending problem where the right pelvis is sitting higher and the right rib cage is sitting lower. And this goes back to the answer I gave about the quadratus lumborum issue earlier, just a few minutes ago, is that this pattern is happening in 80 to 90% of the cases because of some older problem in the same leg, right? That your body is responding by trying to get off of that. In 20 to 30% of the cases, the problem is occurring in the other leg, which is now shifting over to the right side to get off of that older problem on the left. And now your brain is saying, I can't do this anymore. I've got to get off of that. And it hikes that side up. So that's that's the next thing that we need to figure out is which leg is this happening on? And then, usually a lot of medical providers say, oh, it's starting in the back and it's going down the leg. Well, that's true from a very basic sense of sciatic pain, that usually something is happening here. But the real question is, why is it happening here? And typically things just don't happen on their own here. They happen in response to deeper problems in the lower body system. And so that's what I'm talking about. It's either coming from the same leg or it's coming from the opposite leg.
BMAC has not said anything else since.
Okay.
If you come back, we will address it or.
All right. And to give you a plug, that is in my pain patterns book on how to figure out which leg that is in.
I'm glad you have it handy.
The source of the issues.
So Kate, who is the carpal tunnel one, has another follow up. It's more, well, I can't even read the whole statement. I can read most of it though. So do you have other favorite exercises for neck and upper back health for computer users? Stretches or strengthening, always helpful. The idea of rounding the back for planks is a new one for me. Looks interesting. She does watch her posture a lot and try to avoid forward head posture most days. But some days things feel tight and sore. It would be good to prevent that. Pain is often between neck and top of shoulder, between the shoulder blades and spine. And it continues, but I can't see that part of the comment.
Absolutely. Mike, do you want to tackle this one?
Well, what are you going to talk about? Lifting the rib cage or your one-sided stretching? Or
well, first of all, I'm going to talk about ergonomics, and then lifting the rib cage, and then explaining why it's in the upper neck and upper trap, or lower neck and upper trap, because of the scapula.
So I can do the setup since I'm sitting at a computer chair right now.
Ergonomics is going to be critical, so you're perfect for this.
So oftentimes when you're at your computer or workstation, you want to make sure you're a good height off the floor. Your feet can touch comfortably. Your back is supported. You're sitting upright. But then what you can try, Rick is talking about, is some people have a depressed shoulder blade on one side. So it's not sitting correctly, which can cause a lot of tension between your shoulder blades or your neck muscles as well. So you can try elevating your armrests more if they're adjustable. So like mine, if I have one really low and one really high, you can see on me right now, like this one is going to be way more depressed. There's a lot more strain on your muscles up here. So if you can get some support in there, that can help. But some people's chairs are limited, so you can try putting pillows in there or building it up some other way.
Yes. So this is a bilateral carpal tunnel syndrome issue. So likely both shoulder blades are depressed, right? And so the reason, Kate, Mike and I are talking about your shoulder blades is that there are significant muscular attachments from the shoulder blade into the cervical spine and the base of the skull. When the shoulder blades aren't operating correctly, they cause chronic strain via usually the levator scapula, which starts at the corner here and to see 1 through 5. And then what happens is that you develop chronic strain in the top of the neck. It can also cause chronic headaches too. So the most common problem with the shoulder blade is like what Mike said, they are resting too low. We call that having depressed shoulder blades. This typically happens if you have a strong yoga, Pilates, dance, gymnastics background, anything like that. All of those disciplines typically promote scapular depression because they value having the appearance of a long neck. To create a long neck, you have to depress the scapula, which then causes this dysfunction. So what Mike is talking about is elevating the arm of your chair so that the arm of the chair is now pushing the shoulder blade up higher for you while you're sitting. But one of the things that when he was demonstrating that, you'll notice that his elbows were out to the sides of his body. That kind of neutralizes the benefit of elevating the arms of the chair. And you saw like Mike's arms, they likely can't come in any closer. So most chair arms are stuck out here somewhere. They're too wide for the body. Your arms shouldn't be that wide. They should be close to the body and elevated like this. And I bet that if this issue is coming from your neck, that if you put pillows, like Mike said, you get a bed pillow, you fold it in half and you put it between your body and the chair, then you can rest your arm on that, and that will rest the elbow higher and closer to your body. And that's where your keyboard should be. Wherever the elbow is resting, where it's down the seam of your shirt here, is where the keyboard now should be. And so when that happens, your scapula are fully supported and it unloads the structures from the shoulder blades to your neck. I think we talked about this in our book, The Top 3 Fix, didn't we, Mike?
Yeah, I think it's in there.
Yeah, I think so too. So that's another book I co-wrote with Bob and Brad, is Top 3 Fix. We talk about neck pain, and headaches and things like that. But anyway, Kate, that's what I would really tackle. This ergonomic piece is so crucial for a lot of people because so many people work at a desk. And the arms of the chairs are just like Mike's. He's demonstrated perfectly how poorly arms of chairs are.
My other work desk, it doesn't even have armrests. So
oh my God. Don't even tell me that.
That's at my other job, but I don't sit in those too often.
Yeah.
I'm up and moving around a lot there, but.
So anyway, Kate, so I mentioned, not to plug it again, but I mentioned this a little bit in my new pain patterns book. But it's also, I think, in our Top 3 Fix book. And then also I've written a book for neck pain and headaches that also in more depth describes the depressed shoulder blades.
You did guess it. She said my good dance posture. That's what I thought.
Yes, that's often the cue.
I was not a dancer, and sometimes I have some shoulder blade dysfunction, but that's more
you
from
look like
old.
A dancer, Mike.
Oh, thank you.
You look like a dancer.
Those are more from old injuries. I think I just compensate. That's what mine are from. But
thanks for that feedback, Kate. I just can't tell you how often I see these very types of problems in people with your type of history because of, and likely you were probably a pretty good dancer. The best dancers are the people who were most devoted to their craft are the ones who are in the most pain because they've adopted the strategy of depressing the shoulder blades to create this long, perfect looking posture, which is so valued in dance. And it wrecks a lot of people's careers in terms of dance and things like that because of chronic headaches, migraines, neck pain.
Probably
and
have
neurological symptoms.
You probably have very strong feet and ankles, though. So look at the positive.
Yeah.
I can't walk on my toes. If anyone else has some questions, we'll be live for about 10 more minutes. So feel free to chime in, or if you have a follow-up question and already asked one. She just said, so what is good, healthy standing posture for shoulder blades and neck?
There you go, Mike. You can teach the lift in the rib cage.
I'm sitting right now, but I guess we can talk about that. Sure. So that was from Kate again.
Do you want me to teach it?
Yeah, it doesn't matter to me. I don't know how you do it. I know you go here, and then you just work on thinking of lifting your rib cage up versus squeezing your shoulder blades back. Because if you could see me right now, if I'm trying to get good posture like you did in school, you squeeze your shoulder blades back. I'm going to do this for about a minute, and then my mid traps are going to get fatigued here, and I'm going to go back to this posture. So instead of thinking of that, you like to think about your sternum lifting up, and then my mic is too low, so I'm in bad posture, but... So unless you want to explain it a different way.
Yeah, I'll just go through it step by step so Kate can do it with me. All right. Since you're on the call, Kate. So I'm going to ask you, Kate, to stand up and put one hand on your chest and the other hand on your belly. And I want you to take a nice deep breath in. And you'll feel your whole rib cage rise. And then exhale, and you'll feel the rib cage go down again. And if you're not sure, go ahead and take one more deep breath. Feel the rib cage rise. Feel the rib cage lower again. All right. So we're going to take another deep breath. Inhale. This time when you exhale, don't let the rib cage fall all the way. It can fall 99% of the way, but not that last 1%. So keep it up maybe a millimeter or a centimeter higher than normal. And you can exhale all the way to do that. All right. So what you should have noticed is that by keeping the rib cage up just a smidgen, you should have noticed that some tension has developed in your abdominal area. So this is your abdominal, these are your abdominal muscles, of which there are many layers and they are massive. They are holding up the whole rib cage system for you. This is their job. And now the second part of this is that you want to bring your arms down by your sides and roll the shoulders around loosey-goosey so that your arms are like two dangling ropes by the sides of your body. And when you completely relax your shoulders, you'll notice that you just lost the abdominal contraction and the rib cage position. The reason is, Kate, is because you've tied posture to squeezing shoulder blades together and likely down because of your dance training, which lifts the rib cage to do that, instead of using your core to lift the rib cage and relax the shoulder blades. The arms should not have any part in postural strategy. That's an artificial construct that's been developed by these disciplines to create the posture that everyone seems to value in those disciplines. But in the real world, we should just be able to lift our rib cage ever so slightly, a millimeter, centimeter at most. Feel the stomach engage naturally. You don't want to contract your stomach. It will happen all by itself. And then walk around with loosey-goosey arms. So that will take the pressure off of your neck, because now those shoulder blades are not sitting too actively low, and they can sit more where they should be sitting, and you'll be relaxing the muscles that are actually depressing the shoulder blades by adopting this type of posture. Hopefully that's clear.
Your instructions were much more elegant than mine. I suppose you've taught this a few times. I'm like, I know what he's going to talk about, but yeah. I'm not good at explaining it.
Yeah. Practice makes perfect.
I guess. Yeah. If we have any more questions coming in the next 5 minutes, feel free to ask them. We will try and answer them. Rick, do you want to mention again where people can find you at?
Oh, yeah. My website is rickolderman.com. I don't do a lot of social media stuff, so that's basically the best place to find where I do everything. I do have a YouTube channel too, where I have tons of videos to help people and answer their questions there. But I've written several books. I have home programs for people to purchase if they want a deeper dive into fixing a lot of their problems. And yeah, I think that's about it.
Yeah, and your programs have like a group coaching aspect to them.
Correct? Oh yeah, yeah. So my home programs. So one of the nice features is, when you buy my home programs, you're eligible to join monthly coaching calls with me. And that happens every Thursday evening. And they cost $20 for the month. And you get 4 one-hour calls with a group of people who are looking to solve their pain. So it's a sweet deal. And, a lot of people learn from other people on the call with their questions. So a lot of things come out in these calls, and it's a really, I don't want to say cheap, what's the other word? Inexpensive way to have access to me. And on these calls, I test people, we go through testing and we go through solutions. And so that way I get a week to week understanding of what's going on with them, and I can help them work through their problems. And usually the exercises in my home programs are the exercises they'll use to solve those problems. The group coaching calls just help us narrow down and be more specific to their, specific issues.
Barbara, the scoliosis gal, did chime in again. She just gave a more detailed explanation of what she had. She must have found her old records. I'll read it. You can address it if you want. Some of these things I think it's still better to see in person, but she just said spinal stenosis in your lower back with arthritis. In your middle back, mild scoliosis with arthritis, scoliosis as well as prominent multi-level thoracic DDD, which is degenerative disc disease. This is my official diagnosis for my back from my x-rays from 2021. My right side of back from neck down. My back is the worst for pain. Also, yes, lower back. I am 56 now. Just wanted to know exactly what she had.
Yeah, so this I think goes exactly into how we describe when you have a curvature to the left, you'll have a right scapular rib hump, you'll have a right rib hump, and that disrupts the scapular function. That's likely why you're having right-sided pain, is because the scapula is kind of stuck on one side or the other of this rib hump that's been created. However, I'm going to guess, is it Barbara?
Yeah.
I'm going to guess, Barbara, because it's mild scoliosis, that rib hump is either very tiny or non-existent. And so it makes me wonder if you have a right side bending problem instead that's causing the rib cage to be depressed on the right side and depressing the scapula, which is then tractioning these muscles between the shoulder blade and the neck. So I can't say this really medically, but when I see mild something, I really think, okay, well, who doesn't have mild scoliosis? Because so many people have scoliosis, functional scoliosis, and no symptoms at all. It's just a normal part of asymmetrical living. And so my focus would be more on the right shoulder blade and neck pain rather than the scoliosis. I'm not sure if the scoliosis is really a driver of that. And then did she say that she has right back pain too?
Mm-hmm.
Okay, so this kind of confirms the right side bending issue that I'm talking about, is that if you have right back pain, typically this goes into, you likely have a right side bending problem where the right pelvis is higher, the right rib cage is lower, which creates compression on the right side of the spine, causing unilateral back pain on that side. Because this rib cage is lower, the shoulder blade rests on the rib cage. And so if the rib cage is lower, then the shoulder blade is lower, but you have connections into the neck from here. So this disrupts the whole upper body system on the right side. So what I would do is focus, again, Barbara, think about, why are you having a right side bending problem? Why are all these things happening on the right? Do you have, and typically it comes down to older problems in the right leg that have not been addressed. Or if you have an older problem in the left leg and you've been offloading that to get onto the right to not address it, then that is the source of the problem. So really, this sounds like, we should be addressing the side bending, the sources of the side bending first, so that we can set the rib cage and the scapula up for success to solve that.
We had one more question come in. If you want, we can answer it.
Sure.
Okay. Yolanta said, differentiate between piriformis syndrome and sacroiliac dysfunction symptoms. Well, a Google search would probably give you really quick answers, but I would say oftentimes with SI joint dysfunction, if like a simple test you can try and do is if you're in pain, you can take a belt and then you put it on, you don't put it lower, but you put it kind of on your upper pelvis bone region here. And then you tighten it. And if it feels better, that could be some SI joint dysfunction. That's kind of one test you can try. Do you have other recommendations?
Well, this question, this gets into why I look at things so differently than other practitioners, is because this is a component thinking question. Is it an SI joint dysfunction, meaning is it this joint or is it this muscle that's right next to the joint? And in my clinical way of looking at this, to me, it doesn't really matter. It's all, this is both. You could have elements of both. You could have SI joint dysfunction and piriformis syndrome. This doesn't have to be one or the other. The real question is, why is this hurting on my right side? That's the question that should be answered, not whether it's this little thing or that little thing. And so again, this goes into the dysfunction of a right-sided, is this a right-sided leg problem that's then causing the pelvis to act abnormally, turning off likely the gluteal muscles on the right side, which is then over activating the piriformis to make up for the poor gluteal dysfunction? Well, the piriformis crosses the SI joint and inserts into the piriformis, into the sacrum anyway. So, I mean, it's probably both things, likely due to an older right-sided problem that has not been addressed correctly yet in 80 to 90% of the cases. And again, in 20 to 30% of the cases, it'll be coming from the left leg that you're compensating to get off of, and it's overloading the right side and it can't handle it anymore. That's how I look at these things, not trying to decide which is, it's so minuscule. I mean, they're both addressing the same area of the body.
Yeah, and a lot of like the limitations you have is going to be similar between both. Like you probably have some
Exactly.
type of limited mobility on that side.
Right. If
And
you have
yeah,
piriformis syndrome, you're likely going to have some type of SI joint dysfunction. If you have some type of SI joint dysfunction, it's likely that you have some piriformis syndrome too.
yeah,
So why beat your head against the wall trying to decide which is which? Is it 60% here and 40% here? It doesn't really matter. What matters is why that whole system is failing.
yeah. So I guess check on what issues you notice and then see if you have, limitations with one side versus the other. And then if you can't diagnose it with Rick's programs, I guess go see someone in person.
Yeah, but likely, again, not to plug it again, but this kind of stuff is exactly what I address in my pain patterns book, because it's all about chronic pain, dealing with the low back system and which is often fed by the lower body system. So I explain what I meant by this is that most practitioners think in a component thinking standpoint, which means we have to test each tissue to see what each tissue's involvement and what's happening at each tissue, when where I look at things is from a systems standpoint. And so while it's nice to know which tissue is more aggravated than another tissue, we have to understand why the tissues are irritated. That's the true answer, in my experience, to fixing chronic issues. And so that's called a systems approach, which is not what we're trained in physical therapy school so much.
No.
And what I've been describing this whole call with side bending problems and depressed scapula and all that kind of stuff.
Is there any tip you want to give Yolanta? They just asked if there's any exercise that can help with both. Or some of it's going to depend upon actually visually seeing you to see what deficits you have.
Yeah. So, Yolanta, likely this is happening because of poor gluteal function during walking. So what I would say, and the reason the glutes don't work well when people are standing or walking is because they're locking their knees. So what I would say, Yolanta, is instead of doing an exercise, focus on keeping your knees unlocked for the next few days, which will help turn on those gluteal muscles, which will then absorb the stress from the piriformis and the SI joint and track your hip joint better and see if this starts to resolve the whole issue. It's likely an anterior femoral glide issue, which means that the femur head is likely sliding forward in the hip socket as you're moving around. It's happening because the gluteal muscles, which are the primary controller of the hip bone, are not turning on appropriately when you're standing and walking. They're not turning on appropriately because you're likely locking your knee when you're standing and walking.
We had one more question come in, but I'm just gonna say to Fran, I see your question and I acknowledge it, but it's very in depth. And since you have an MRI, I would see what they're going to do with that. Do you want me to read it to you, Rick? You can. It's pretty specific about.
I've got to get going.
Sure.
It's been over an hour now. So
yeah, Fran, go in, get checked out, get your MRI done, and then we'll be back next month to answer more questions, or we're also live on the main channel too. So I apologize we didn't have time to get to yours, but I think getting a professional to check that out would be better than us spewing stuff on the internet. So, well, thank you everyone for joining us. Rick and I will be back next month again for another live. We will notify you on Facebook when we are doing that. Well, thank you for joining me today, Rick.
Thanks, Mike. I had fun.